Good evening, everyone. A warm welcome to all of you joining us for session 2 of the International Workshop Series organized by the Bangladesh Institute of Innovative Health Research, BIIHR, in collaboration with the Global Consortium of Global Health Actors, Leaders, and Thinkers. We are thrilled to continue this global dialogue with another impactful session featuring two back-to-back panel discussions moderated by Professor Maheshwar Satpathy, an esteemed global health leader and activist. Bangladesh Institute of Innovative Health Research is a non-profit student-led research organization that promotes research culture among students and early career researchers. Nearly 40 students contribute as research assistants and over 10 serve in core managerial roles. BIIHR is actively conducting public health research and regularly organizing trainings, workshops, and seminars to build capacity among emerging scholars. Global Consortium of Global Health Actors, Leaders, and Thinkers operates under the Global Health Leadership by Global South Initiative, a flagship project of the Global Health Forum. The consortium brings together global health experts, researchers, practitioners, and policymakers, especially from developing and underrepresented regions, to collaborate on transformative research that drives equity and systematic change in health. So, some ground rules for our participants for this session. Please stay muted during the session unless you are invited to speak. Use the chat box actively for any questions or reflections. Attendance will be tracked from start to end. Unless you are present from start to end, your attendance will not be counted. Maintain a respectful and inclusive environment throughout. We now begin our panel discussion 1 titled Collaboration in Global Health Spaces and Global Health Diplomacy. Joining us today, Professor Joe Thomas, Director of Learning at AICHM, Melbourne, and Editor-in-Chief of Critical Public Health, UK. Professor Maheshwar Satpathy, Professor of Global and Planetary Health, Director, Lead, COE, ECCPH, Utkal University, India. At this point, I warmly invite Professor Satpathy to introduce our speaker more fully and begin the moderated discussion. Professor Satpathy, over to you.
Okay, thank you, Faisal, for such a brilliant introduction and setting the rules and guidelines for the meeting. So, good evening, everyone. I'm Professor Maheshwar Satpathy. I'm here to basically lead the panel discussion. But before we go to the panel discussion, I would say a little bit about what this particular initiative is all about. This is an advanced certificate program which is created by Global Consortium of Global Health Actors, Leaders and Thinkers, GCOGH, which operates under the Global Health Leadership by Global South Initiative. It's a flagship project by the Global Health Forum. The consortium brings together global health experts, researchers, practitioners, and policymakers, especially from developing and underrepresented regions, to collaborate on transformative research that drives equity and systemic change in the health. So therefore, you are all welcome because health is everyone's business and everyone should have a voice in talking about health. So today, we have an eminent researcher, professor, a change maker, and among us. And he is none other than Dr. Joe Thomas, who is already on the screen. And hopefully you are able to see him. And a lot of people are slowly joining. And so hopefully we have a big momentum coming up in the next few minutes. And in the meantime, let me introduce Dr. Joe Thomas to all of you. Joe Thomas, Dr. Joe Thomas, very famously known as Joe, my friend for about 20 years almost now. So we know each other very, very, very long time. I'm very happy to see him after a very long time on live call again. And so COVID disrupted many things. One of the worst things which happened is we couldn't see each other as much as we should have as friends, family, and everyone. So let me introduce quickly about such a luminary person. Words will be actually very little to describe his stature, but let me try. So Dr. Joe Thomas, MSc, PhD, FRS, PA, that is Fellow of Royal Society of Public Health, is an accomplished author, academic, diplomat, and a global leader in public health, rights, and development issues. Dr. Thomas has been active in global health and social development for over 25 years. He has excellent leadership qualities and outstanding administrative and specific technical expertise in public health policies, reproductive health, and health rights. He also works with fragile settings, research data analysis, and preparing scientific reports. In addition, he, he has proven excellent experience in the administration and management of complex multi-stakeholder public health projects of high-level strategic engagements and proven expertise in a cross-cutting multicultural work environment in Africa and Asia. Dr. Thomas has demonstrated his expertise in developing advanced syllabi for public health education, high-value strategic partnership with governments, UN agencies, and non-state actors, drafting complex MOUs and strategic bilateral agreements, and establishing multi-stakeholder alliances and multi-country research projects. He is a member of the board of directors of several NGOs and INGOs. In addition, he has established 3 schools of public health and developed facility for teaching masters in public health, philosophy, disaster management, and sustainability studies. In fact, if I tell you, he is one of the early founders of public health schools in India. So he has contributed significantly to the public health education system in India. Dr. Thomas worked as the executive director of an intergovernmental organization of 26 governments that is known as Partners in Population and Development, that is PPD, permanent observer to the UN General Assembly, focusing on sexual and reproductive health. In this capacity, he represented PPD at the UN General Assembly in New York and the World Health Assembly, that is WHA, in Geneva. He spoke at the UN General Assembly on antimicrobial resistance, sustainable development goals, migration and refugee compact South-South cooperation. Reported to a high-power board of directors, 26 ministers of 26 member countries. He chaired by the Minister of Health of the Government of China. The vice chair was the Health Minister of India. Dr. Thomas has hosted several international interministerial conferences in Yogyakarta, Indonesia, Dhaka, Senegal, Dhaka, Bangladesh, New Delhi, India, and Beijing, China. Look at the diversity of the countries he has actually represented, and he has led the public health initiatives. Dr. Thomas was the organizing secretary of the 12th International Congress on AIDS in the Asia Pacific. That is one of the largest congresses I have been to, and let me tell you my personal experience. It's just a wonderful place to be and to share and exchange the amount of information, get to learn about so many very important critical work that is happening in the area of HIV/AIDS and STIs and overall infectious diseases. So Dr. Thomas initiated the Global Commission on Aging in Developing Countries. The Commission's goal was to enable gender equity and right-based policies and programming that would improve the quality of life of the aging population in developing countries, including 25 member countries of PPD. Dr. Thomas was the founding director and professor of social determinants of health and social policy at Jodhpur National University. In that capacity, he supervised PhD students and created a scholarship program for 150 staff members from the Ministry of Public Health of Afghanistan to take their MPH courses. Dr. Thomas also carried out several strategic short-term consultancies for the World Health Organization. He worked as a consultant with the Premier's Office, Provincial Government, KwaZulu-Natal, South Africa, to assess the Premier's flagship program for poverty reduction, health equity, and youth and women's empowerment. With UNAIDS, he carried out Engaging an Enemy within HIV Response of Indian paramilitary forces, a case study of the Assam Rifle. See, look at the diversity of the population he has worked on again. His earlier experiences include working in an Australian government-supported advisor's capacity for the Ministry of Health in East Timor and as a regional manager of the Northern Territory AIDS and Hepatitis Council in Darwin, Australia. In addition, he worked as a research fellow at the Chinese University, City University of Hong Kong, and La Trobe and Deakin University in Melbourne, Australia. In Hong Kong, he also worked with the refugees detained in refugee camps, addressing the refugee population's health and community support needs. He has led a multi-country, 11 countries, project on HIV-related stigma, discrimination, rights, and aging in developing countries, that is 22 countries. His postdoctoral studies and publications at Oxford University have focused on policy issues related to refugee detention. He has authored 4 books and over 100 peer-reviewed papers. So, Dr. Thomas has lived, worked, and consulted in India, Hong Kong, China, Australia, East Timor, Nepal, Bangladesh, Mongolia, South Africa, Rwanda, Burundi, Geneva, the UK, and 50 other countries. Dr. Thomas is a visiting professor at the Global Institute of Public Health, Kerala, University of Health Sciences. Dr. Thomas worked as the senior lecturer in public health and national post coordinator at the Health Institute of uh, uh, at the Institute of Health and Management in Melbourne, Victoria, Australia. Professor Thomas is the chair of Global Health at Sustainability Solution Foundation and the director of learning at the Australian Institute of Community Health Management in Australia. That's all that I could actually say for now because we have a huge panel to moderate. But his profile is so prolific and so versatile that actually I'll take the entire 3-4 hours to actually speak something about it. Still not be qualified enough to probably summarize enough. So that's all from my side. So I would welcome Dr. Joe Thomas to please come on camera and present his talk and give this lecture to our learned audience who come from all over the world, literally. I'm sure more people will join us in the meantime while he starts his presentation. And then, followed by his presentation, he will speak about 15 to 20 minutes. And after that, we'll have a panel discussion, which will be moderated by me. And then we'll open the floor for audience question and answer. That will be the structure of today's session. Please keep yourself muted. Please keep posting any comments, any reactions that you have in the chat, and let Professor Joe Thomas give his excellent presentation, and which I am very much looking forward. So the mic is all yours, Dr. Joe Thomas. Thank you so much, and I look forward to hearing you.
Thank you very much. Namaskar. And it was a very generous introduction. I particularly thank you for that. And I can see there is a large number of audience from Bangladesh. So, Kamanache, Balo. And why I emphasize Bangladesh is my health diplomacy practice I have done from Bangladesh. I lived there for about 6 years as a senior health diplomat. So, what I am presenting today the experience came from Bangladesh that is significantly contributed towards my presentation and my understanding about health diplomacy and also the global health. As an introduction, I wanted to say is global health and health diplomacy is going through a serious challenges or crisis. We know that recently, for the last 3 months, is very significant in the history of global health and global health diplomacy, particularly from the point of view of developing countries' perspective. So we know that the United States they withdraw from WHO, and also they canceled the USAID funding for the global health globally. So at one stroke, within the last 3 or 4 months, probably about 15,000 people working in the global health is literally vanished from their work experience. So this is one of the significant part of the experience of global health when you try to understand. This has got implication on all the countries because USAID supported global programs are covering most of the countries, and either they cut down dramatically most of the programs or the staff is withdrawn. So this is the one area which when we look at global partnership, this is what we have to keep in mind. And second, I mean, I've been told that about 90 to 100 people are going to attend this session. This itself is showing the new forms of global partnership, global collaboration. And I just wanted to emphasize the wording, and I'll be using the word collaboration, and there are other words like alliances, partnership, so consortium. This all denote almost same meaning. But I just wanted to highlight the issue of the language in global health because the way we use certain language in public health and global health is very important. To begin with, global health and international health, the difference between that. For example, international health is relationship between few countries, whereas global health is health of the globe. So I just give an example about it. And before I get into to understand the complexity of collaboration in global health and global health diplomacy, I just want to introduce some of the key words which will be used or which will be used in this session. So when I try to introduce that keywords, that will give you the complexity of the session, complexity of the issues you're trying to talk about. The first word is about the power dynamics in collaboration. Collaboration has got power dynamics. And the second is about hierarchies in collaboration. Collaboration is not necessarily a neutral relationship. There are hierarchies involved in quite often. And what are they? Then, when you talk about collaboration, what is the terrain of collaboration? Where are we going to collaborate? The institutional mechanism, the terrain of collaboration. Then, broadly, when you talk about collaboration from the global south and south south collaboration, that's another nature of collaboration. Now we know that there are global north and global south, north south collaboration. Then when we talk about collaboration, issue of colonization comes in. How we decolonize public health, because many of the concepts, practices, methodology, theories are still influenced by colonial ideas, colonial influences, colonial themes. So, decolonizing public health is one of the important aspects to understand the opportunities and the scope and space of the global collaboration. So, this I just wanted to highlight this. The next is about collaboration is not a neutral effect. It has got risk as well as benefit. So, this is another important issue. You might remember that. Then, when you talk about global health cooperation, global collaboration, what is the governance mechanism? How this phenomena is being governed? Who governs it? What is the governance mechanism of the global health collaboration? Then, when we apply this to the global health diplomacy, who are the actors of the global health diplomacy? Who practice? Who is the main players? And how do we understand them in the context of collaboration? And finally, what are the examples of global health diplomacy? So what I introduce is some of the key words which will come through our discussion, which are on my presentation. So I just introduce the keywords first before I get into that. Normally, when you present a paper, we write the keywords.
Joe, excuse me, Joe. Could I just disturb you for a moment? Could you please put the camera in front of you, because your face is cutting. No? Like tilt the camera. Increase it. Yeah.
Is it all right?
Now you're better.
Yeah, all right then. Thank you.
It's all right now. Yeah. Thank you.
Again, let me just introduce few issues about the background issues. Today, when you talk about global health collaboration, many of the institutions are being challenged. Global health institutes are being challenged, and the relevance are being challenged. The global health practitioners are being challenged, and this is particularly becoming important for people who are marginalized, and they are being challenged. They giving? I mean, they're being nullified. Their contributions are undermined. So this is the one thing we have to keep in mind, that when you talk about health diplomacy and also the level of partnership. But when we get into the issue of global health partnership, global health diplomacy, when I introduced this issue and I was talking to somebody, then they said, when you talk about global health collaboration, what is the theoretical basis? Because from a public health point of view, very rarely we talk about the theories of public health. But if you want to get the depth of a discussion, the intellectual depth of any discussion about global health, global practice, we have to look at the conceptual areas which is driving the ideas. What theoretical foundations we can derive to look at the issue of global collaboration, global partnership. Because many people think that this is a very pedestrian idea, partnership and collaboration. What is the conceptual or theoretical basis for that? So I looked into that. There are very significant theoretical foundations or theoretical concept we can borrow to understand the role of partnership, the role of collaboration in global health, because this has got nuances, and significance. So one of the theory which, when I try to understand the theory, is what you call the complexity theory of public health. When you talk about global health and public health, it's about complexity. The word complexity is applied when more than one factor is influencing one phenomena. Global health is influenced by several variables, several phenomena. And these variables are national policies, global institutions, key players, the teaching institutions, and also the actual diplomatic activities where it's being taken place, being practiced. For example, the World Health Assembly of WHO, that is the general body of the World Health WHO, also UN General Assembly and Security Council. So these are the two major areas in which global health diplomacy and partnership is being practiced and being I would say being acted upon that. Then there are different institutions. When you look at unpacking the partnership issue, there are major eight intergovernmental organizations or bipartisan agencies who are actively involved in the global health diplomacy as well as a partnership. They are UNICEF, UNFPM, UNDP. So, like this international UN agencies also play a very important venue for collaboration. And sometimes they act as gatekeepers. They decide who is going to collaborate, to what extent you are going to collaborate, and what themes are being brought into the international level. For example, when you talk about global health, my keyword unpacking, I mentioned about global health. How do we decolonizing? The decolonizing is quite often it is not heard in the global health dialogue, global health diplomacy, because when you look at the leading global health, public health institutions, schools of public health, these are mostly from the global north. And that itself, they act as a gatekeeper for who is going to come in the global leadership level. So this is, I can see that most of the participants today are from the global south. And some of you legitimately should be at the global partnership level, at the global leadership level, at the global health. So, but at the same time, you have significant barriers, intellectual barriers, institutional barriers, and also operational barriers. So, to understand that barriers, my background discussion may give you some ideas about it. And this may not give you a roadmap towards how to be an active partner, being an active collaboration in the global health. But at the same time, this will enhance your understanding about global health institutions, global health mechanism, how this partnership being gatekept. And this is explained through what we call it as a public health complexity theory. So when you talk about partnership, it is again the issue of complexity. The complexity in terms of global health financing. Who is financing the global health partnership? Quite often, global health partnership is financed by global north. Global health universities are the one who supplying leadership and the human resources for the global health. Just that keep in mind. At the same time, people from the global south, developing countries, also creating their own global health networks. And that networks bring in tremendous power and capacity. Number one, to set the agenda. Number two, that will give us a springboard to the leaders to come up on an operational level and also idea articulation level. For example, quite often, I participate several international conferences, online, offline. Very few conferences you see about 100 participants from the developing countries. From that point of view, I appreciate the contribution of the Bangladesh Institute of Innovation and also Maheshwar's personal contribution towards bringing together. So this is another important thing. You need your own institutions which can promote and provide opportunities, provide platform like this to be active in the global health dialogue and diplomacy. And utilizing the technology, important part of it. This technology gives a tremendous cutting edge, and now the AI, artificial intelligence, is going to come. We have to see how that is going to contribute in changing the terrain of global health diplomacy. Again, I want to highlight another issue. In many countries, they have a global health ambassadors, but not in the developing countries. Probably this is one thing you have to keep in mind. You have to negotiate, you have to inform your own government in developing countries the need for creating global health ambassadors. Australia got a global health ambassador, United States got a global health ambassador, UK got global health ambassador. Most of the developing countries, the global health ambassadors are the one who coordinating the terrain operation, the gatekeeping of that country's position in the global health. So that way, if you don't reach out, you don't network with them, your opportunities are quite often become very limited. But counteract this is, probably you may have to create new avenues. Particularly, you have to advocate with your own governments the need for developing countries nominating health ambassadors, because health ambassadors act as a focal person for promoting national health issues and negotiating at the international political relationship. And this will be explained to this complexity theory. The details of this is in my handout that I have elaborated on that. Right now, I'm just highlighting this theoretical basis. And also, the another concept is called transdisciplinary approach. Transdisciplinary approach is approaching the global health collaboration, global health diplomacy, not from the biomedical point of view. Remember, health and medicine are two different things. Medicine is about treating, health is about mostly about prevention. So this you have to keep that very important aspect of global health, and global health from a medical point of view and a socio-ecological perspective. And again, another thing, when you look at the public health institutions and the public health agencies, quite often they are dominated, they're controlled by from a biomedical perspective. And increasingly, socio-ecological leadership is emerging to lead the global health discussion, global health dialogue. When we looked at the social determinants of the key determinants of a disease like diabetics, diabetics from a medical point of view, it is called as a lifestyle disease. But when we looked at the review literature, about 51 variables are influencing the diabetics prevention, care, and treatment. Out of these 51 variables, this lifestyle is a concept which is not defined. Lifestyle is a very loosely proposed idea. It can be anything, it can be many things for many. But this idea of lifestyle is used by mostly by biomedical point of view. But ultimately, when we unpack it, what we see is that you're blaming the patient. Your lifestyle is the cause of the disease. But at the same time, one of the major reasons for diabetics is number one, when you look at again, if you unpack what is the lifestyle, there are two factors: the physical activity, the intensity of physical activity, and also the kind of food you take. These are the two aspects of lifestyle, which in relation to in non-communicable chronic diseases. But let me come to this idea of how the naming of certain issues in public health. These 51 variables, the physical activity is not decided by one person alone. You should have a environment where we can have safe walking. In many of the developing countries, you don't have a safe footpath. You look at the Dhaka street, you don't have a footpath.
You have 10 more minutes.
Sure, I'll come. I'll wind up. Thank you for letting me. So the language is an important part in understanding global health and also to understand the space in which. The next idea is about the planetary health framework, and the health is understood in a planetary health point of view. And there are a few other concepts which I'm just leaving it. When you look at the global health diplomacy and the governance, the global health diplomacy is about getting things done from a political perspective. How do you negotiate for the better outcome for the health at the political level? When you negotiate for the trade agreement, when you negotiate for the bilateral agreement, when you negotiate for the border security issues, because there's a concept called health in all policies. And the health in all policies also has sort of implication on partnership and collaboration. So what I'm giving you is the global terrain about the area of collaboration. And this is also very clearly implied in the health diplomacy. Again, what is the result? Why it's important we should look at the collaboration. The collaboration provides better health outcome. And we know that 431 million people can access essential health services because of the Global Health Partnership. Partnership for the physicians, partnership for the public health practitioners, and also how, for example, this meeting have the capacity to influence the quality and thinking of the practitioners, which will indirectly and directly contribute towards the capacity for prevention. And again, when you look at, and sorry, I'm just skipping through. And I just wanted to summarize. There are 7 dimensions involved in and health diplomacy. Health diplomacy is about navigating geopolitical, ideological, national interests that might hinder solution for have a benefit for everybody. So this is an important part of the understanding about health diplomacy. For example, right now, this month there is a global health World Health Assembly will be held in Geneva. About 180 items will be discussed, and one of the major contribution will be the global pandemic treaty will be resolved. A global pandemic treaty is one of the major partnership of 192 countries, which you may have to take a look at it, how you can involve in the national level at the global pandemic treaty. And the 7 dimensions, one is negotiating to promote health in the face of other interests. Health is competing with other interests. What capacity you have to negotiate with other interests. Establish new governance mechanism in support of the health. Creating alliances in support of the health outcome. You're looking at a maternal and child health partnership, every woman and every child partnership. These are some of the examples of the partnership. Building and managing donor and stakeholder relationship. This is another important part of partnership. Responding to public health crisis as and when it is coming, not only from the biomedical perspective, from the socio-ecological perspective, how we're going to respond to the global health crisis. Improving relationship between countries through health. And interestingly, global health diplomacy is contributing towards reducing conflict between these countries. How do we utilize it? And also improving relationship between countries through health. That's another major contributing factor that. And finally, global health diplomacy contributing towards peace and security. In nutshell, partnership collaboration is considered as, even in the popular language and also in the biomedical framework, collaboration and partnership may not be high in the area of global health and public health, but this is an area which is not explored much. And I congratulate the organizers who decided to focus on this, the collaboration and what is relevant for the participants. And these are the way we understand, and I hope my brief presentation has given some idea about the idea of partnership and what is its scope and how it can contribute towards better health outcome. And thank you very much for your attention, and I'll be happy to take questions and discussion. Thank you very much.
Thank you, Dr. Joe. Such a wonderful presentation, such an insightful presentation. As always, Joe is full of energy.
Thank you.
And he's never growing older. Like every year I meet him, he is growing younger. See, look
Thank
at
you.
his face, the glowing, radiating face. You know, so he's such a wonderful friend of mine for the past 20 years, and every year I get to talk to him. He's doing something new, setting up some new institution, achieving some new milestones. So he is so inspirational, and that's the first reason why I chose him as the first panelist to be invited to this particular advanced session. I wanted all my participants from all over the world to listen to such a stalwart in the area of global public health and infectious diseases and such areas. It is like an eminence scholar in the area of global health security, refugee studies, migration, and also global health diplomacy. He has taught that course. He is in fact actually posting an online course offline right now. It will be online, he told me, very soon. And so now we have a structured, moderated panel discussion. So I'll be asking you a few questions, and these are very basic questions. I know that we will have very, very wise answers to these questions, but I'm sure all our participants will benefit greatly by listening to all the responses to these questions. So they will help them to think more and achieve more insights from him, such as scholar of great international. So I have a few questions to ask you, John. So you have already spoken a few things, but still I have a structured questionnaire to ask you, and I would be very grateful if you could answer me precisely on these questions. Okay, so the first question to you is, how has collaboration in global health evolved in recent years? You as a global health scholar has been very active globally. You have so much of multiple years experience. So how do you see the change and evolution in this global space? How has that collaboration activity changed? Has any significant change that has brought your attention?
See, I'm monitoring from my personal experience last almost 25 years the nature of global health partnership, how it's coming, and who are the players, who are the institutions, and also be part of some of those global partnership. But I was very hopeful about the contribution of global health partnership till recently. But the U.S. president's the executive orders is dramatically is upside down many of the global health partnership. But I wrote an editorial about this. What are the opportunities given by global health partnership because of the U.S. withdrawing from the global health arena? One of the issues is that till now, U.S. academicians, the U.S. scientists, they were the leaders of global health partnership. So right now, there's an opportunity for global health leadership coming from the global south. For example, I can give a very concrete example about it. In United States, they have about 71 WHO collaborating centers. Since WHO withdrew, probably this 71 collaborating partnership has to be reassigned from United States. And I would say that this is an opportunity for the global south to bid for it. You work in your own countries, which institution may be able to bid for this collaborative partnership institution, WHO collaborative partnership. These are very important global partnership leadership. I'm just giving a very concrete example about it. And these 71 institutions need to be reassigned. And I assume that WHO has to take that leadership instead of waiting for the United States to come back and give some patents for the global health. So financially, it may have reduced, but at the same time, global health leadership, there's a vacuum. And right now, if you look at the global health leadership, these are coming from major about 10 US universities, schools of public health. Now that leadership is being challenged. And are we ready to take up this leadership? So this, I think, probably we have to seriously think about it. I would even say that this network should pass a resolution and inform WHO, take immediate steps to dismantle the WHO partnership institution of the United States and resettle it in developing countries and build the capacity, negotiate and build the capacity. And maybe this network should act as a catalyst for doing that. So that way, there are new challenges as well as new opportunities. So this is my summary. The challenges are new, opportunities also new. So I look forward to looking at new players coming in. And who are these new players? Leadership from the global south. And probably when you look at the global health leadership, very few women are in the global health leadership. And few LGBT community members are at the leadership level. So this traditional excluded community could take up the leadership. So this is my hope in the partnership and collaboration, the global health level. Thank you.
Definitely, Joe. I completely agree. In fact, that the lack of representation is one of the major issues. If the global south is not actually as represented as it should have been, and talking about LGBTQI population and women and other people from socially disenfranchised communities, they're hardly represented. Most of the global health space is completely filled and tested with the global elites, and we know them, right? So your remarkable insights in this area is definitely praiseworthy. And thank you for saying that yes, global consortium should work towards actually passing a resolution That is one of the biggest goals with which we are working. That is one of the objectives with which we are working. Our goal is to create the next generation of thinkers, artists, thinkers, and leaders. And we want to strengthen them so that they are ready to take up the leadership position. And we'll definitely try our very best to pass a resolution as well as try to communicate to WHO and other UN agencies so that there is some amount of space, some amount of opportunity for people like us from the global south. So definitely. So the next question to you: what are the ingredients of a successful international health partner, according to your own personal experience? Because you have led so many big missions, you have led so many international initiatives, you have created institutions. What do you think? What are the critical ingredients of successful international health partners?
If I may look, I don't have any immediate solution or formula to solve that. And when I look at my experience, it is maybe at the right time, at the right place. But at the same time, your intellectual capacity and capacity to absorb information and knowledge and process it is an important part of it. And you should be at par with anybody at the global level, whether you are from XYZ university. So you constantly invest in your knowledge building. So this is an important part of it. And second, your ability to reach out to other people. But at the same time, the other party may not acknowledge you. You may reach out to a global leader in global health. They may not even acknowledge your presence. They may not even reply your paper, your letter. But at the same time, that consistency and persistence, an important part of it. And the third, look at the opportunities. And that's very, very precious for people from the developing countries. And see, one of the main opportunities to network is international conferences on global health. But international conference on global health is extremely prohibitively expensive. And also it is normally held in the developing countries. And you may be able to get a scholarship, you may get a ticket, but your visa may be rejected. So these are some of the dynamics of how people are systematically being left out. So because I have organized international conferences, I organized scholarship for international conference. So I know the difficulties of getting scholarship for international conferences. The 12th International Conference on AIDS in Asia Pacific, I managed 600 scholarship, full paid, fee paid scholarship. And that's the first time that level of scholarship. But to raise that funding, I had to use all my diplomatic skills. And also, there are global diplomatic dealing and wheeling has to be done because I did some international political diplomacy to get this funding for this conference. I had to get favor for, I had to do favor for some health ministers. I had to do their political bidding. So I'm just giving a very frank discussion about it. So global health diplomacy, the skills you required is number one, you should be at the top of your subject. That nobody can challenge you. And the human resources, whatever you do, there are barriers. But barriers there, everywhere there are barriers. In whatever field, there are barriers. But that should not put you off on that. Then second, always there is an opportunity that will come through. If you're persistent, it will come through. See, for example, this group, you suppose 100 people write a global health agenda from the developing countries. You write your name wise and you send it to the editorial. Probably I can publish in the critical public health. I'm not promising. Probably we can do that. A global health agenda from the global south. Sign all of you, but creatively and critically look at what are the global health challenges from the diplomacy, collaboration, partnership, financing, decolonizing, and identify about 10 challenges for the global health. So these are the skills. You create your own opportunity. And the most important opportunity is that your 100 people are here from the global south. You come out with a statement of this 100 people from the global south on global health leadership. What are the opportunities? What are challenges? But I'm just giving a very broader framework. And this could be one of the meeting and conference discussion. What is the global health agenda from a developing country perspective, from your own agenda? Each one you come out with the 5 priority areas. And this will be called as that Delphi method. Through Delphi method, 100 people, this is methodologically very sound, you can do that. So that itself, immediately the global health community will take note of you. Because if you look at any statement, any consolidated statement, any consensus statement on global health is normally organized by a global health, public health university from United States or UK, never from Utkal University taking the leadership, never from Bangladesh Institute of Innovation Health. So, but you put your name on it, you create, think about it, and take some systematic approach for creating that. I'll be as an editor in charge. I mean, in chief, I have some leverage. I'm not saying that I have full leverage to push some ideas, push some editorial. Think about it. So, this is a way you build up your, you create a space for yourself at the global level. Thank you.
Definitely, Joe. We are on board with you on that idea. We are in fact working towards that. That is one of our biggest objectives. That we have to come up with something which possesses policy level changes, not just research level insights, but policy level changes, makes people think, and we should be able to not just nudge, but be sufficiently able to stimulate and challenge maybe the global health space by putting forward ideas from the global south. Right now on screen, I can see there are about 164, 65 people, but the people keep coming, they keep dropping, and it's happening. We are noticing that. So we have more than 900 applicants from all over the world, from more than 100 countries. That is the cohort that we are actually talking about. And many of them are facing issues in joining due to logistical issues, I don't know. But they are watching your lecture on YouTube. So by tomorrow itself, you'll see will cross probably 10,000, 20,000 views. And it's quite a big achievement in the area of global health, public health, and science and technology, because not many people actually watch these kind of lectures. So that's the reality on YouTube. People watch entertainment things, but they don't watch the things which actually should matter to the people. Okay, so I'm talking about decolonization. I have an interesting question which I've not listed in my area, which question list, but I would definitely ask you because you are the right person to ask that question. And I keep talking about it on LinkedIn all the time. So let me ask you very frankly, like, what do you think? Why are so many Western, European, or American elite professors talking so much about decolonization? Whereas we know for sure that colonization is the result of those countries and those entities. So, and when you talk about decolonization, are we actually sufficiently and authentically, genuinely interested in decolonizing and investing ourselves emotionally and intellectually in giving the space to the people who we call colonized? And are we actually meaning only again a kind of a ritual, some sort of performative ritual, or do we really mean to create some amount of real change in the process? Because I have lots of questions. I mean, like I can have a literal panel on that topic itself. Since our topic is a little different, so I'll restrict my questions to this. But I would definitely like to have a very free and frank and any kind of free response from you that you would like to say to this Global South audience, because this Global South audience is very, very impatient, let me tell you. They are very impatient. The kind of discussion happening in groups. We have 25 working groups, let me tell you. The kind of discussion they are having is very, very, very interesting. And they are like contagious. The kind of energy, the vibaciousness. I mean, like, you'll be very surprised if I give you entry to one of the groups, the kind and nature of interaction they have, the dialogues they have. So please say your views.
And thank you for asking this issue about decolonizing public health. To begin with, if you look at the history of public health is evolved as a medical science, an extension of this. So, the theories of public health is derived from biomedical understanding about public health. So, this is a one part of it. And the modern medicine itself is evolved from the colony. And if you look at some of the schools of public health, even the name still carries the messages or shades of colonialism. I'm not giving the names of some of the schools of public health, global schools of public health. Then next thing you have to look at the agenda of masters in public health. Just an example about it. Quite often, any masters of public health, you have about 25 to 26 subjects. And the subjects, the themes and agenda are not necessarily from the health agenda of the developing countries. See, many of the developing countries, for example, there is something called medical pluralism. Means there are different countries or there are different health mechanisms. But how do you integrate that into the mainstream health seeking behavior? So this is the one issue. It's an extension of the colonialism. I'm not saying that all the alternative medicine systems are foolproof, but that also should be scientifically validated. So unless, because we are talking about health from a different point of view, all the health related interventions should be scientifically validated, whether it's modern medicine or traditional medicine. But this idea of there is a scope, there is a room for traditional medicines in the public health, it is, you never heard about it. For example, public health intervention. Very rarely you see the methodologies or traditional systems of medicine and their contribution towards modern medicine. And people may say that that is not scientific, but we have to remember that some of the essence in the traditional medicine that are waiting to be scientifically discovered. And you do a clinical trial and you do a scientific study because according to WHO, the concept of evidence, because modern medicine gives the top evidence and the evidence is coming through clinical trial. At the same time, there are hierarchy of evidence. Clinical trial evidence may be the top, but then there are opinions and experience is also evidence. For example, in most of the modern medicine, there is something called expert opinion. Expert opinion is not necessarily based on evidence and data, it's opinion, perception, experience. So, most of the traditional medicine, we could say that they are opinions consolidated through experience of a collective population. That is proof of evidence, but that proof should be strengthened. So, this is the role of state, this is the role of the government. How do you enhance the proof in non-allopathic medicine? I'm not saying that all should be accepted. So this is the one aspect of decolonizing. The idea of there is a contribution of non-allopathic medicine or local traditional system of medicine has got to do something about contribution to the health and well-being. It is not the
I
full
think
proof.
there are numerous ways of conceptualizing decolonization as a concept itself. Like, for example, you talked about dominance of Western universities, elite universities, and designing, defining, conceptualizing how global public health should be taught, and how it should be practiced even. That's something which always talks about that colonialism is too prevalent, So they do not have a space for other economies, cultures, and societies to actually have a voice in defining and even structuring how public health as a discipline should be taught, should be disseminated, should be practiced. So I think there is a lot of space for having lots of more culture debate about these issues. But I hope in the future we'll have a separate panel on such important issues, because as probably we will not have sufficient time, because we can spend an entire day talking about decolonization.
Right.
Still, we will not come to a consensus about it, right? So let me go quickly, because I have a set of questions ready for you. You know that. So, what potential barriers exist in cross-border collaboration, especially between the global south and global north, and how can we address them effectively? But I would request you to be a little bit brief now, because I have a few more questions to ask. Yeah. So, thank you.
See, one is about what are the barriers of global health diplomacy and in, bilateral agreements. Number one, the idea of global health diplomacy is not taken over by many of the developing countries. If you talk about Bangladesh, India, or South Africa, the idea of how to integrate health in the diplomatic area, that is not taken into consideration. See, for example, in the the diplomatic corps, there is no people specializing in health. There may be few doctors, but doctors not necessarily public health experts. So, number one, the idea of health as an important part of international relationship, it is not pushed properly by the people from developing countries. Second is a human resources issue. The people who have got expertise, understanding, and ability to analyze what are the global health implications of bilateral agreement, trade agreements, or other international agreements. So this is the second part of it. And the third is that no resource allocation for strengthening the global health diplomacy. So this is immediately, I would say briefly, three areas. There are a few other areas, but I highlight these three. Also, I have a request to all of you. Please subscribe to my YouTube channel. Some of these issues I discussed in, and the link is given in my handout. Thank you. Next question, please.
Okay, definitely. I'm sure our participants will be very happy to subscribe to your channel. Okay, let me go quickly to the next question. So, how can global health diplomacy save policy and funding issues? That is about to take place because now that we have a very rapidly changing funding scenario in the world.
See, one is about, the funding is not necessarily the dollar amount that is there. There are human resources issues. For example, I mentioned about bidding for the 71 WHO collaborative centers. So it's not only resources, it's a matter of human resources. For example, each developing country institutions, they have to see carefully out of the 71 institution, which one you can build and what is your capacity. And if I use them in Bangladesh, there are about, I think, 10 schools of public health. Look at the syllabus and can you bid for any of these WHO collaborative centers. In India, there are about 100 schools of public health. Look at your syllabus. And this 100 schools of public health is 50% is controlled by biomedical perspective, and other 50% is coming from the socio-ecological perspective. This issue of standardizing the syllabus, because 50% is under UGC, the other one ICMR control. So this is itself is there is an intellectual tug of war is going on that. And so I'm looking at global health, and the global health is also not part of the public health teaching in many of the countries. In India, out of these 100 schools of public health, hardly one or two universities looking at global public health. In Bangladesh, I taught in one of the North-South University a course on international health, global health. So that time, that's the first time there is a lecture on global health and international health took place in Bangladesh. So I'm just giving an example about it, the capacity for human resources, and you may have to negotiate with your own national government for additional resources. International funding may be reducing. That's an opportunity because there are less international experts are going to come. I mean, I may be cynical, but maybe that's a fact. Thank you.
Yeah, definitely, definitely. Like there are a number of challenges that we have to navigate as global health researchers and thinkers and actors, in this space, which is extremely contentious. Once again, it's not just pure or medical science or public health, mechanical public health. Global health is a very critical field which actually sets up everything that happens around health globally. So obviously that is supposed to be a little bit more challenging if you are choosing to work in that space. So my next question is directly related to that, but a little bit very important in the current climate. So if you look at the current funding climate, how should global health actors based in the global south, you said in the beginning of the lecture that a lot of people lost their jobs and livelihoods due to the recent funding. So how should the actors, global health actors based in the global south navigate their journey to maintain a voice and at the same time keep up their livelihoods?
See, one thing is I noticed about 15,000 people working in the global health lost their employment. But this is 15,000 mostly from United States and some other agencies working in the developing countries. So it is not impacted hugely on the people from the developing countries. So you have to keep that in mind. So how do you use as an opportunity? For example, see now this May 20th, the Global Health Assembly is going to take place in Geneva. So probably this was a concern you should put forward to the WHO executive committee. This is a view. For example, the 15,000 people from the United States losing their job, that should not be an excuse for them to be redeployed into developing countries. So this is an opportunity, this is another possibility. And the second, and the WHO itself is employing probably about 2,000 people from the United States. The moment they withdraw, the moment they withdraw, I think it's very normal that they also should, WHO should take a very serious look at their continuing contribution. Because US, I'm not a personality, I know many of them personally as a very good friends, I work them on a collaborative basis. But as a political issue, when the United States is withdrawing from the global institutions, and interestingly, I looked at it, and the schools of public health in the United States, they never made a statement about US being withdrawing from WHO, very limited voice from the global health community from United States in condemning the move from United States and what do you call decimating the global health, the human resources. No resources from the faculty from the United States, public health faculty, no students' voice, no schools of public health voice. And I personally make this as a major concern. And they should have been at the top level for resisting it, for challenging it, at least on a writing their publication, editorial, and their voice is very weak. This should be articulated very clearly from the people from the global south. For example, this group, you should demand for the schools of public health in the United States, they should have a very precise and significant voice against United States withdrawing funding from the global health. But also, this is not a charity from United States. They get a diplomatic benefit. It is not a charity. When they say they invest $1.5 billion, they invest in global health, the diplomatic privileges are tremendous. For example, Global Health Assembly in Geneva, there are 180 agenda approximately. Each agenda, United States staff will have an opportunity to comment on it because they're funding it. Also, let me tell you that one of the major determinant of global health is war. War is contributing to the death and acting as a determinant of global health and well-being. And the war machinery supported by a country is negative contribution towards global health. So when you contribute to 1.5 billion for health, at the same time, suppose you support $1 trillion for war machinery, you almost nullify your contribution towards global health. So this should be articulated very well. This should be put across on a global dialogue. Thank you.
I think we are going to do that, Joe, and we will seek all your support and help in this process. When drafting that, conceptualizing as well as disseminating that. So thank you for saying that without mincing any words, and that's exactly what I wanted, and I think I don't have to go to anybody else other than you for saying that. So brilliant, and that's what I wanted to hear from you as well. The next question to you is like, what role do you think the young researchers can play in fostering meaningful collaboration among South, the global South, South-South exchange, South-South communication?
See, one is 160 people came. That itself is a contribution of global South youngsters, and I know it's a very tedious process to sit in a video conference for some time, but these are the learning curve and learning opportunities. And you suggest what should be the agenda, not necessarily somebody one of us saying that. You suggest what are the agenda, what agenda need to be discussed, and second, your learning curve. That learning is a personal journey. Remember that you may have academic institutional learning, but at the same time you have to expand your personal journey of learning. And most importantly, for example, I'll give an example about take the leading 10 public health journal. You may not be able to subscribe all that, but you can subscribe the what you call the table of content of all the journal. The table of content will give you about what is the agenda, which way it's going to go, and just give an example about it. And also try to get published in international journal. I know that the cost of publication is different, but some journal there is limited opportunity. But and enhance your skill on presenting your findings at the global level. Whenever you do it, that should be your aim. Your publication should be at the globally peer-reviewed publication to present your credential. And it's a difficult process. And many of the schools of public health or they don't train you to do that kind of expertise on the global level. And your public health education itself from the global south will not help you to put yourself in the global level. That you have to compensate by yourself because you have to also negotiate with the faculty to redesign your global health syllabus, your school of public health syllabus. For example, you can come out with some optional courses in global health based on your discussion and understanding what is missing in the global health in the Indian schools of public health or developing country schools of public health, Bangladesh schools of public health, in any of the countries you're coming from, look at the syllabus. And are they helping to becoming a global leader in global health? So this is a question you have to ask yourself. Thank you.
Okay. Please, everyone, please stay on mute and don't raise hands. We'll have a structured question answer just after this, okay? Because we have few more questions to ask to Professor Thomas. We don't get hold of him every day, so I have to ask him all the questions that I have to ask. Okay. So the next question is, what role do journals like Critical Public Health play in setting global narratives?
Okay. Probably I'm one of the few editor-in-chiefs from the Global South acting as editor-in-chief. So editor-in-chief comes with a lot of privileges. And some strategies, I don't know whether I could disclose it because of the commercial reason. I'll tell you one thing. I personally take special effort to promote scientists from the developing countries. What I do is, see, quite often the first time when you look at it, their paper may not be that quality assured. So normally, what you do, you reject it. You don't see. For example, I last year I rejected about 800 paper. At the same time, I accepted about 1,300 papers. But I look at, I can see when a paper comes in, whether it is from a fresh graduate, a fresher from a developing, I can see from which country the affiliation, I can see it as an editor-in-chief. I have the privilege to see who is submitting the paper. So what I do is I give them the first round and I send it to the peer review. Most of the peer reviewers, they do a fantastic job. And if the researcher is willing to address the concerns raised by the reviewers, and that will be a good paper to begin with. And instead of two reviewers, sometimes I send it to four people. So even a mediocre paper, reviewers give a good comment, it can be revised into a certain minimum quality. And when they accept, and when the authors they redo that, most of them they address the criticism coming from the reviewers. And it will come back to me, then I'll take a look at it whether they addressed all the concerns raised by the reviewers. Even if they raised it, sometime I send it back to the author to revise it again. So I give additional opportunity for people to improve their paper. So this is the one thing I influence the agenda of this one. And the second thing is that I write editorial. That editorial, the recent editorial is about opportunities for global health in the crisis context. That's one of the latest editorial. Earlier, I looked at the issue of the need for disaggregated data. I hope you understand that all data you give it to gender breakdown, age breakdown. But according to SDG requirement, you should have at least minimum 8 variables as a disaggregated data. Your ethnicity, your income, like this, there are standardized SDG 17 called partnership. Also, there are minimum disaggregated data as part of the data collection. You take a look at it, the important idea of disaggregation, because disaggregated data is important for understanding health equity and health inequity. This is more important from the point of view of developing countries. Most of the data in developing countries are not disaggregated only on 3 or 4 variables: age, sex, normally, or economic status. It stops there. It will not look at your ethnicity, it will not look at your marginalization, it will look at your vulnerability status. There are standardized 8 variables. So this is one of my editorial, and that editorial is being cited in many other papers. So intellectually I influence, by providing opportunity I influence, and also I mentor people and encourage them to write article. So this is the way I encourage. And also I supervise PhD students to influence their writing and their thinking. Thank you.
You are a powerhouse. There is obviously no
Thank you.
dearth of opportunities that the global south scholars will take from you. So I think I would be the first one to take, because I also consider myself an emerging researcher. So I would be probably the first to contact you. You know me personally for so many years, but I'll be a little less greedy here because you have more younger researchers than me. So let me go to the last question, but not the least, very important. What advice would you give to the emerging scholars entering the global health spaces in global south? Because as they look upon the current climate, what is happening in the world war, conflict, lack of funding, this, that, everything probably sets a very pessimistic tone. So, in this sort of scenario, what sort of practical advice would you give to them so that they can probably navigate their careers more effectively and maybe contribute something effectively to the global space?
I'm not saying that I'm giving advice. I'm sharing some of my observations. Observation number one, global health is about global transformation. Remember that global health is about transformation. Number two, global health is about prevention. Number three, global health is about addressing the health inequity. Global health is about the health and well being of the excluded population. So, that way, global health is a mission. It is not a career alone. So, you have to build up into that passion about global health. So, global health should be looked upon as a passion, as a calling. So, this is my observation about it. Okay, if you're looking for a job, international assignment, it may give you an international assignment, it may give you an international job, but this is something beyond that. You are getting an opportunity for being part of a social transformation. For that, you should build up your personal capacity, personal skills, your values, and your understanding about the global dynamics about it, and also your willingness to stand with the people who are excluded. If you're not willing to take up a position and stand, and you don't have much role in global health, that I would say very clearly on that, then you have to understand very clearly there are two broad streams of global health: biomedical models of global public health and the socio-ecological models of public health. And the key of socio-ecological models of public health is understanding social determinants of health. Understanding and unpacking social determinants of health. For example, disease and illness is created by social structures to large extent. The biomedical, biological, and also the genetic factors are quite often very limited variables. 60-70% of the variables which a person's disease and illness is related to is socially determined, ecologically determined. So this is social structurally determined, and understanding you grasp it in your own social context, how the society is making you sick. So that should be your mission to understand. Thank you.
Definitely, definitely. Great, excellent insight, Joe. Since we don't have much time left because we are waiting for the next panelist to join us. He's already ready to join us. I don't think we can actually get the audience to ask you, but there are lots of very interesting questions asked in the chat. Maybe one question I can read it out for you. Maybe you can respond to one of them.
And also you can forward that question to me. I'll definitely answer. I may take some time. I definitely answer each and every question. Please feel free. And also, if you want to write to me directly, please do. And my WhatsApp and my email and YouTube, all the channels, my communication channels are there. So please reach out. I'll definitely answer to each and every question. It may take some time, but definitely I'll answer that. Please, next question. Thank you.
Yeah, Dr. Joe, at the moment we have more than 250 participants on call. I just wanted to update you on that. And one question I would read it out for you because I think it is important that you respond to it on call. And other questions we'll compile it for you and we'll send it to you. And they can also contact in case they are interested. So Martin J wants to ask you, I really love the suggestion Dr. Joe is asking us to look at. And my question is, could the WHO do a good follow-up if any countries from the global south emerge as global leaders in health? Especially since the American government found a lot of misappropriated funds into unwarranted sectors like terrorism and food. This is what he wants to ask. I'm not very sure what he means, but maybe you can, based on your experience in global health security and diplomacy, you can really shed light.
I'm not very sure I understood that. If you're talking about the WHO misappropriating funds, and and also the southern leadership coming to the global health. Remember, the WHO Director General is from the Ethiopia, and I know all other five candidates for the WHO election, except one, all from global south. And I have seen very closely. I worked as a senior advisor to WHO on many projects, and I was I mean, I was a key advisor on setting up a gender equity and right unit in WHO. So that way, I had an opportunity to work very closely with the financial resources, how it allocation. I will not say that WHO is misuse the funding, but like any other organization, there may be a certain people misbehaving or inappropriately behaving, or resources are being misutilized. But in general, systematic misappropriation WHO, I don't think so. But the only difficulty is that WHO head office in Geneva got about 8,000 staff. Whether that staff should be in Geneva or the country office or regional office, that's an issue you need to look at it. Whether this 8,000 people sit at Geneva or send them to a regional office and or country offices. So this may be an issue which you have to really take into consideration. This is my opinion, but at the same time, I'm not saying that they are not working hard, they are not important enough, but a practical issue because money is less. So what you do? Maybe you demobilize them, send them to country offices or regional offices. I know this is not a very palatable solution. There are many personal issues are involved, but I'm just giving you one suggestion because this is a reality. WHO is going to cut large number of staff, but instead of that, they could be established or maybe reassigned.
Yeah, definitely. Okay, the last question, because there are so many questions dropping in the chat right now. Just want to ask one question. Before that, after that, we will disperse. We'll have a break for 5 minutes, and then the next panel will start. In between, the attendance form will be dropped here on YouTube as well as here in the chat. Okay, and we'll have only 10 minutes to fill the attendance form. We will not have more time. Please, Hazel, please, if you're on board, please make it ensure. Thank you. Okay, the last question is how can we promote more national and global funding on health prevention and lead to policy advocacy on health prevention promotion intervention?
See that you had to look at the health budget of the national governments. In most of the developing countries, the health budget is 2%. And the 2% is actually is a zero investment because inflation and other expenses, 2% is negative. You're not investing anything new. So you have to advocate with your own governments, increasing the allocation for health. And the thumb rule is that it should be between 10 to 14% of the national budget should go to health. If I may use the example of India, India's health budget is approximately 2%. But I think Bangladesh is little more, about 3% of the national budget. So your own governments, you have to advocate, you have to look at first what percentage of the state budget, national budget is invested in public health or the health in its totality. And the idea of public health and the clinical medicine, these are two different issues. Investment in prevention. Public health is about investment in prevention. And within this 3%, investment in prevention is 0.005. Because prevention in if you're not preventing diseases, you end up in paying heavily for your medical cost. So a shift in the global health towards prevention, a shift towards public health, a shift towards increased financing of the global health and public health. So this is my suggestion.
Okay, any lasting parting words, Professor Joe Thomas, the eminent Professor Joe Thomas, because you have already said so much of valuable wisdom in the past 1.5 hours, but I just don't want to let you go. So I want to still hear some lines of wisdom so that our young participants here especially get benefited from your wisdom. Any parting thoughts?
I would say thank you. Thank you very much for being with me for this conference. And I'm sorry I didn't manage to reach out to you. And that's one of the limitations of this in the classroom. That's what I delighted to do on an engagement basis. Please do two things. Take my email ID and also subscribe to my YouTube channel. And please write to me. I promise I'll reply each and every question you're going to ask. And you can leave my email ID on your attendance list, please. And please send the email or the questions to me. And so this is what my parting message. And also, I'll be happy. I'll be happy to come back, and I'll be happy to part of your engagement. I mean, your whatever activities you do, I really appreciate, and I'll be quite happy to mentor some of you if you're looking for a mentor, and also technical support, and also to act as a co-traveler. Thank you very much.
Definitely, Joe. We definitely want a mentor, and I'll be in touch with you for that. Besides that, just to address, lots of people are asking for your phone number, email ID, etc., and LinkedIn ID. So that's something which we'll address. I'll definitely drop your email ID and phone number on the main group so that everyone can have it. First thing. Second thing is that we'll compile all the questions from the teams and we'll send it as a Word document to you so that whenever you have time, please respond to us and we'll share it in the group so that everyone can learn from it, not
Thank
just
you.
one individual.
Thank you.
That's all. And so I thank you so much, Professor Joe Thomas, for sharing the stage with us and sharing such valuable wisdom and experience that you have accumulated over the past 30 years from all over the world. And I don't want you to go, but unfortunately I have to because the next panelist is just about to come on the stage. So we'll have 5 minutes break now and we'll start exactly at 7:30. And thank you, Joe. If you wish to stay on board, you can stay on board and to listen to Dr. Suren Kumar. He is a health tech entrepreneur, an emerging researcher from Global South, from India, and he is contributing in a big way. And we are looking for people like him to change the way global health and public health is reimagined. So I'm sure you'll really love to listen to some of his thoughts. If you are interested, please stay on board. And we'll have a 5 minutes break now so that you also get break and all participants get break. And we'll start exactly at 7:30 p.m. in Indian Standard Time.
And thank you for invitation, and I'll try to stay on. But the time wise, it's past midnight now, so that's only concern. And anyway, I thank genuinely that this gave an opportunity to understand my own ideas about global health, and it gave me time to regularize and to systematize my own thinking. Thank you very much, and I hope to interact with you in future. I look forward to further opportunity. Thank you, Maheshwar, and also thank you, Bangladesh Institute of Innovative Research. Thank you. All the best for all of you. Bye bye.
Quite here, Professor Joe Thomas, for such a compelling and enlightening discussion.